you so much, Anisha. Thank you to the organizers, the IHW Council, for the 7th edition of the CSR Health Impact Summit and Awards. And I know that this has really become the central event for CSR, and to also see the innovative work being done by various organizations, institutions, organizations and individuals. So I have a power-packed panel with me, and this segues from the discussion that we had, the excellent discussion that we had in the first session, which looked at CSR, its evolution, the need for partnerships, sustainable development, and what can organizations, governments and partnerships do about it. But this discussion is another very interesting and timely one, because it looks at non-communicable diseases, it looks at rare diseases, and it looks at preventive and promotive care from the lens of CSR. And I could not have asked for a better panel here, subject experts, practitioners who can actually answer those questions for us. But let me just lay the context here on NCDs, on rare diseases, and on preventive healthcare. As per estimates, 42 million people died of some sort of NCD in 2019, of which a large chunk of it was cardiovascular disease, 18 million, and about 10.1 million due to cancers. And this really shows the burden of NCDs, which have now overtaken infectious diseases in the past 3 odd decades or so. And the Sustainable Development Goals actually outline, 3.4 speaks about reducing mortality from NCDs by 1/3 by 2030. But given the current pace where we are today, it is estimated that we will achieve that reduction in mortality by 2089. So not in 9 years, in 66 years. It's time that we don't have, and it's action that is needed on the ground. Similarly, when we talk about diseases, rare diseases, it's a cohort, a complex cohort of 6,000 diseases. Now, how do we direct funds towards these diseases, especially because they are underfunded or because expensive to treat? So how do we look at that? And then we'll talk about preventive healthcare as well, which, as per some estimates, is the most effective way of reducing the disease burden that we have in our country and around the world. By some estimates, it takes only $1 to measure BP per person, and that itself can have a cascading good effect on a person's health. So there's a lot to unpack here, but first and foremost, I'd like to bring in Dr. Hiremath into this. Since we are discussing diseases, and specifically NCDs, rare diseases, and the role of preventive healthcare, I'd like to get a practitioner's perspective on the disease burden that NCDs now has in India and in the wider global community.
Thank you, Karan, for the brief introduction. And at the outset, let me thank the ISW Council and the CSR team for inviting me. Well, to make a social impact in the country, yes, I was invited, seeing the profession where I am practicing. I am working as a senior cardiac surgeon at Sathya Institute. The place itself depicts what a social impact it does today in the country and across the world. The number of heart diseases which is increasing, that is what we look at, the non-communicable diseases, is very rampant. Today in our country, the current statistics is around 1.4 to 1.8 children every 100. That is, at least 1 to 2 children are born with congenital heart disease. And in the next 5 years, we see the rapid rise of at least 5-fold increase. So in the next 5 years, we have 10 children of every 100 being born with congenital heart disease. The reasons are plenty, whether it starts with consanguineous marriage, late marriages, nutrition of the mother which can be looked into, and a number of diseases or person that the mother undergoes during the course of pregnancy, where we are looking at. Not only that, the global impact of what India is heading towards in heart diseases. At present, 60% of the world's heart diseases are in India, and 2030 we will be the global leaders for world heart disease. Today we are sitting here in this forum, and today the current statistics, every minute 4 Indians are dying because of heart diseases, whether it's a child up to the adult. That is the current statistics today. And what we are doing, yes, CSR has come into an action today. In fact, I am first time attending this meeting. I am happy to attend this meeting to make what CSR can make an impact, not only on the hospitals or a disease process it can act. It can collaborate with associations. Like for example, Indian Association of Cardiothoracic Vascular Surgeons, where I'm sitting as a secretary today. It will be shocking for everyone that today in our country, 80% to 90% of these seats are going vacant to choose cardiac surgery. 10 years down the line, if you and me want a good cardiac surgeon to operate on your own heart, you won't be having a cardiac surgeon in India. That's where we are heading towards. And that's where I am making an impact on this, to work on this, where how we can prevent this. If we don't prevent, what the youngsters can do. Why there is a lack in this specialty, that's where ground level I am working on these things. And that's where CSR also can make an impact on this disease per se.
Absolutely right. And we're very glad that you are practicing and we're around during the time that you are practicing. But if we look at non-communicable diseases, till about a couple of decades back, or even till about a decade back, it was called lifestyle diseases. But
Yes.
that has changed. How do you foresee the change that has emerged, where even rural populations, economically depressed regions of India, are also now facing this giant tsunami of NCDs? How do you see this panning out?
Yeah, especially we don't know, multiple genetic factors play a role. The lifestyle, the Indian lifestyle, the eating habits, what are there. In fact, if you ask me, when we were kids, the outdoor games were more. Today, each kid as he is born, I think to keep the child silent, you show a mobile, and that becomes a sort of an addiction. You have n number of patients. I come from Bangalore, wherein you have Niman's Institute, and every day you have more than 50 to 100 children being admitted there for de-addiction of mobile units. This is where the country is heading towards, and that's where you go on eating. And if you today, in our own families, we adults, we end up seeing the TV, we end up seeing the mobile, and end up eating our food. You don't know what you are eating also. 99% of the diseases what we have in a country is just because of what we eat, what is the quality of food we eat, 1% what we think. The gym starts in the kitchen. According to me, I more work towards the preventive aspects of cardiac diseases, wherein it starts in the kitchen. We have to be very much aware what we eat and what our children or our generation eat in the family. It starts from us. Definitely, if the family is safe, the entire nation will be safe. That's where I look at it.
Right. So the context is very clear. Dr. Shetty, I'm going to turn to you now. So we've understood the crisis that has emerged from NCDs. We know that government funding, private funding for healthcare is not going to be enough, because just how widespread the problem is. From your lens, from Biocon Foundation, how do you see NCDs in the entire gamut of your CSR program, and how do you approach NCDs vis-a-vis the CSR lens?
Thanks. So Dr. Karn and Hiremath sir, thank you. That was some wonderful data that you just shared, and really alarming. I'd like to take a step back and talk about what Biocon Foundation is doing to address NCDs. The first thing is that, and I'm sure so many CSR heads here will agree, is that primary healthcare is absolutely the bedrock of our healthcare system. It begins there. So what we've been doing is working at the primary healthcare system in order to enable it in several ways. So we've taken certain principles into consideration, the star field principles for certain, locally, what can we do, in terms of coverage of a population, then what can we do in terms of services, comprehensive services. And that is how, through the lens of these star field principles, we have been addressing NCDs, or non-communicable diseases. A simple thing, like what Sir was saying, is that how do we preempt, how do we preempt non-communicable disease? This is what we are working towards. Case in point is cardiovascular disease. When I was, I had the privilege of working with Dr. Shetty, and he would always tell us that it's no longer the young son getting the old father for treatment, but it is the old father getting the young son for the treatment. So that's the amount of, the prevalence of hypertension then leading on to, cardiovascular events is so high that he said something needs to be done. And that's how we began a small community-based program. And this was about having students as agents of change. We called it the CHAMPS program. What we did is we started training students from high school. We took a cohort of around 100 students, and we gave them a blood pressure monitor, and we told them, we trained them on how to record blood pressure. You have to go and speak at a community level. We were working with an educational NGO, and so they did a lot of community visits. This cohort of 100 students went on to record the blood pressure of more than 5,000 people. 30% of them were detected with hypertension. But what I'm saying is, more than them doing the screening, it was the thought process. This child, it was ingrained in him that, I need to understand what is hypertension. And this year, talking about the spectrum of NCD, we've introduced diabetes. We've also introduced antimicrobial resistance. Because I really feel that it is the students of today and, ingraining it in communities that we can make a difference. So that's our perspective. So Biocon Foundation, I'm sure at other CSR levels also, I feel NCD should begin, at primary healthcare level. And tertiary healthcare, obviously, sir, you're dealing with the brunt of it. But somewhere preventive healthcare, promotive, and also precision public healthcare, that's also gaining a lot of eminence everywhere. It has to be seeded in primary healthcare.
Right. So catch them young was one message. I think that's one way of making that behavioral change very early on. I'd just like to ask you a follow-up question to that. When you approach funders or you approach people who you want to partner with, how open are they towards funding for programs for NCDs and prevention? Do you find them more receptive given the crisis that we have of NCDs, or is the shift been very gradual in terms of funding?
So I'll speak about my experience in Narayana Health, where I was heading CSR, and because that's when we actively approached other corporates for funding, and they were very open to it. Definitely, because Narayana Health dealt with a lot of congenital heart disease, sir, as you know. And so this was one of the areas where we did a lot of active crowdfunding. And obviously, when COVID came, things changed. But we've seen that COVID and NCDs is a syndemic. They've kind of, layered on top of each other to create the kind of mortality which was seen. 60 to 90% of the mortality which we saw in COVID is owing to NCD. So therefore, it's so very evident to us that NCD needs to be a really huge focus area for us. And so funding for this, for those corporates who are engaged in healthcare, working with credible institutions such as Sathya Sai Institute, that it's very important. But also, I think, and this is my submission here, we need to have a systems approach. It cannot be just, funding one surgery or funding one unit or funding, say, a robotic arm. Please take a systems approach and, then drill down. Because what's happening is, and I see that, there are small bits and pieces happening, but how do they then measure up to, say, one goal? So a city, for example, a city such as Delhi, I heard Kamal speak about high five. Yeah, so something like that, these are aspirational goals that a city can have. We have targets. At Bengaluru, for instance, we've signed up for a pledge through Arogya World. So we've said that we'll be doing X number of screenings, but at least that sets a target. And it's going towards a larger system goal, so that's my submission here.
No, that's great. So we've got very good strategies that we've heard about in terms of why we need to do this, how we need to do this, and what has worked. So I'd just like to delve on what has worked, and I'd like to bring in Miss Sudha in this. She's a colleague of mine, and I know that she does some excellent work at A Billion Hearts Beating. And I'd like to just draw out from her the experience that she's had. BHB focuses very specifically on diseases of cardiovascular disease, preventive healthcare, and also in old age homes, etc. So what has your experience been in terms of what has worked and some of the learnings which could actually help amplify this and help it become a bigger movement with other organizations?
Yeah, actually, Billion Hearts Beating itself is we have much before CSR, when CSR law came in force, we have much before that, 2010, we have started Billion Hearts Beating, a campaign of heart campaign to for the awareness of the people, and after over a period of time, we converted that into a trust, and in that we are giving, we are training the people with the basic life support training, because nowadays we can see that lots of cardiac cases are happening after COVID. It has increased the number of heart attack cases, and people don't know how to act, what to do. So BHP has taken under the project Precision to train and prepare first responders, so that we can, and in that we are tying up with the institutions, and also we are the APSRTs, like transport departments of different states. So we are trying to train and prepare first responder as many as we can do, and till date I can say that after COVID we have 30,000 plus first responders we have created. So this is what we are doing, and it's very important. But
no, so that's very interesting to know. So we've heard catch them young, we've heard first responders, because if this the disease pattern is going to change and it is going to spread across the length and breadth of the country with younger people also being afflicted, it makes a lot of sense to actually train people as first responders, so that they can at least provide first aid in a trained manner after having learnt it, and then move people on to higher specialty of care. So thank you for that. I'll just come back to you. But Dr. Vikas, I'd like to bring you into this. We've discussed NCDs, but I'd like to ask you your views on rare diseases, and especially since rare diseases afflict the children and the pediatric population more than they do the adult population. So how has the CSR funding environment been for rare diseases, and what has been your experience, and your organization's experience in attracting both attention and funding for rare diseases?
Thanks, Dr. Karan, and thank you ILC Council for this opportunity, and I really thank all fellow panelists for giving a broad perspective of NCDs now. So just like to say, why this rare disease is also known as orphan disease. Why orphan? Because we are not investing in this disease. The spectrum is 6,000 to 8,000, but in India currently our registry has only captured 450 maximum. As Dr. Karan mentioned, that this disease is mainly targeting children. So we don't have exact study that how many at a time rare disease patients are existing in our country, but if you see our studies, like it varies between 50 million to 100 million, and out of these 100 million or 50 million, 80% are children. Any new rare disease, if you'll see the data, 50% is happening in children. So, and on those 50%, again 35% are losing their life over first birthday. Then between 5 years to 10 years, they are losing 12% are losing their life, and between 5th year and 10th year, again 10% are losing their life, because we don't have disease-specific treatment, disease-specific management. We don't have database. So the priority should be us first to focus investment. So don't make this orphan disease an orphan disease. Become a foster parent and request every CSR to invest into rare disease fast.
So, sorry, I broke your chain of thought, but is it attracting CSR funding? I mean, are you seeing interest in this space to spend on rare diseases?
Why there is no interest? Because we don't have a database, first of all. We have a revised policy of national rare disease in 2021, and for 2017 we have a national registry for rare disease, and I said we have only captured 450 till now. So we have to expand our capacity. There's a provision of 9 Center of Excellence. CSR can easily strengthen these Center of Excellence, the 9 existing ones at least from starting. We have 6 Arogya Nidhi Kendra. Again, we have to expand the numbers. In this, pan country, we have just 12 states which have capacity to investigate and diagnose rare diseases. Even the bigger states like Madhya Pradesh, Gujarat and Kerala don't have capacity to investigate and diagnose rare diseases. So CSR can support state in establishing institutions, research centers. Recently, government has launched National Research Foundation, and government expecting 5% of this foundation will be supported by CSRs. There's a huge opportunity for CSRs to invest into it and support our research in supporting our rare disease. One more thing, the sickle cell anemia. Why I'm mentioning sickle cell anemia? Because CSRs start from specific intervention. Sickle cell anemia is also a rare disease, and government has a vision to eliminate it by 2047 under their National Sickle Cell Elimination Mission. So we can support state and start from a high prevalence state like Jharkhand, where the prevalence is quite high. It ranges up till 40% in some blocks. So the test of sickle cell is not available at a block level. We can support them in providing that. Second, the treatment part, as we know, as per revised national rare disease policy, the maximum treatment support can provide about 20 lakhs, but the treatment varies from 10 lakhs to 1 crore in a year for rare disease. So here, through crowdfunding and other initiatives, CSR can support that. It takes up to 7 years to get diagnosed for rare disease. So why we don't have facilities for investigation? It has an average 3 misdiagnoses to diagnose a rare disease. So there's a huge scope to investment from a CSR perspective in building infrastructure, HR machinery, capacity building, drugs and diagnostic. I just want to give an example of USA. Before 1982, there were only 10 approved drugs in USA because earlier they don't have any national orphan health policy. Now they have an orphan health policy post 1982, and now they have 300 drugs approved by FDA for treatment of these kind of rare diseases. So we too can start on similar grounds.
Right, and it was encouraging to read that the GST Council actually reduced the GST rate on cancer drugs, and I think it makes a lot of sense to extend that to these drugs which are there for orphan diseases. So we are talking about an unfortunate set of diseases, NCDs, which creates orphans, and orphan diseases which don't get enough funding. So thank you for those insights. I'd like to bring Praveen in. Praveen, 25,000 crores is spent on CSR every year by corporates. A large chunk of this goes to health and education. When you look at CSR and you look at your pot of funds, what are some of the priority areas that you look at? And within healthcare, how do you sort of unpack the various call-outs for funds that is genuinely there?
Thank you very much for the question. Well, this is the 7th edition of ISW, and I'm glad that healthcare has become a part of the discussion of the capitalist group also post-pandemic, because pandemic एक ऐसा था जिससे रईस लोग भी मरते थे, इस वजह से ये discussion का मुद्दा बन गया. Anyway, coming to the question, out of 20,000 crores in corporate social responsibility, basically if you look at the healthcare spend, which is going to be close to 4,500 crores, which is like 1/3 of the total spending. So CSR is doing its bit of it, but again the major thing which is going to be important is about the awareness, the resources, the funding, research, advocacy, employee health, community health events, nutrition, partnership, networking, collaboration. These are the things that is going to play a very, very important role in terms of corporate social responsibility, because the funding is not as enough that it can do a lot of things that we have heard in the previous panel too. But what is important is the model, what is important is the application, and these are the few things through which we definitely can think about a corporate social responsibility to intervene and to do a lot of things. Well, if you also look at the government funding, 86,000 crore rupees is there from the government side. So per capita expenditure on healthcare is going to be some 4,400 rupees, which is not enough for one person to my understanding. And there's one of the report which is saying that NCD is going to be of a value of 3.6 trillion USD by 2030. That is the investment to be made for addressing to NCD, and 5 trillion USD is going to be our aspiration for 2025. 70% of our the entire GDP is going to go to NCD if we are going to address. So a lot of things, a lot of efforts is required in terms of corporate partnerships, collaborations. NGOs have to come and they have to play their bit of role for addressing to such issues. Thank you very much.
Right. Thanks for that, Praveen. I think it lays out a very important point, which is on the types of funds that are required. Dr. Hiremath, we don't have those funds. Realistically speaking, even if there is a crowding in of spends, whether it is from governments, CSR funds, private healthcare expanding, and people getting insurance. We're not going to get trillions of dollars in for, eradicating NCDs. And that leads to the fundamental point that prevention is better than cure. How do you see prevention as, or at least preventive health checks as an effective CSR strategy? Because many people like to address issues which exist. This is about an issue which does not exist, but you're removing the potential of. How do you see preventive healthcare within the CSR domain?
Yeah, I will like to tell about the burning desire in the country as of now. As Dr. Sudha mentioned that BLS, Basic Life Support Course, what it tells. If you ask me today, in the country, less than 2% of the population are aware of basic life support services. My aim in association, what we are looking forward is to see that every Indian gets trained with basic life support. Of course, advanced is the one wherein by 2030 we have kept a target. Let's see how we can go ahead, where CSR can pitch in and work. Now CSR makes an impact on various diseases, rare diseases. Yes, I am all with that, yes. But where else it can make an impact? Did anyone question our own selves? Are we getting the quality of doctors today in the healthcare? That's where we need to look at. We from the association are working at, we are not getting adequate quality of doctors what we actually require. If you ask me, if I ask today if Dr. Karn himself wants to undergo heart surgery, God forbid, an example I am giving you, and you can't make a junior surgeon to operate on him. He will not agree, neither the boss will agree, because the margin of safety is so less. You are not going to do any experiments on him. Then how the candidate will learn? That's where CSR pitches in. As Dr. Vikas mentioned, Center of Excellence. There is now the association taken lead to start off a Center of Excellence in research in training these youngsters, and also a homograph bank. Why homograph bank? I'll tell you here. Where children are born with heart diseases, a valve is leaking, you can't replace with a mechanical valve. Today, first time in India, the country has come up with a Make in India valve. One of the companies come up, where Merrill is one of the partners in this. And there, because of the body surface area and the ratio doesn't match, we can't put in children and all. Then what is the alternative? It's an homograph bank. And such building up such banks, like blood banks, every second a blood transfusion happens in the country today. Similarly, we need a homograph valve bank. There are only 7 valve banks in the country. CSR can pitch in and help us bringing. And I have taken an initiative as a secretary of Indian Association to make a world's first free homographed valve bank in the country, and it will help every other countries also. That's where we are looking at. That's where CSR can pitch in also. That's
right. So we are looking at newer areas where investments can flow in, because the impact will be disproportionate to the amounts that we're talking about, and also be curative while at the same time be innovative. So I'd like to bring you in on the question of preventive health checks or preventive medicine as an effective strategy for both reducing the disease burden and also effective use of CSR funds. When you approach funders or you look at partners, are they open to this, and what has been your experience in promoting preventive medicine as an effective CSR tool?
Yeah, for preventive healthcare, people are ready to fund. If you want to start some clinics or any thing you want to do, they are very much. But for the BLS, we are finding it, if still people, as Dr. Sir said just now, how many people sitting here are aware of BLS training? If someone had a cardiac arrest, who is going to save them?
So we can do a pop quiz. So how many people are trained
can
in
you
BLS?
Raise your hands, how many know the BLS course? How many you can count? There are hardly around 6, 7.
So we are in a few safe hands, but not in a lot of safe hands. Yeah.
So when we approach people that we are going to give you this training, we reach out to the people. The first, what is our benefit? They don't see this is going to help them and how this is going to help them. But first they'll see why you are giving a free training to us. What benefit we'll get? Well, benefit is monetary. They don't think this is helping their health. They can save their family member. They can save their colleagues. They can save their nowadays you can see so many things in the social media. Every now and then people are on the dais. They are following even Dr. Abdul Kalam, our president, he fall on the dais. No one knows how to save him. There's so many top dignitaries we have seen. So people are not ready to learn. They're saying, why you are giving us free training? if we have some benefit, we are getting some benefit out of it, but this is not that we want in abroad, in other countries, it's mandatory for every individual to be BLS trained. Everyone should know how to give how to rescue the person, how to save the life. But in India, still the lack of awareness is there. People are still not agreeing, don't want to learn. So after last year, we have struggled a lot to getting people, tying up with them. We will give you the training. This year, somehow we are able to manage to train the frontline workers like police, NCC cadets, and the transport departments. So we have tied up with APSRTC, Andhra Pradesh Transport Department, Telangana Transport Department. They are very much ready to learn. But we find it difficult in metro, like Delhi, when you approach someone, their thinking is totally different. They don't want to learn, or we don't get any positive response. But we want that everyone should be aware of this BLS training program. The challenges we face is...
No, absolutely. Dr. Anupama, I'd like to bring you in here. You just heard Ms. Sudha speak about the importance of partnerships and different types of partners in this. Funding is one aspect, but how important is partnerships? How do you approach it at the foundation?
So thanks a lot for that question, in fact, and I'd like to talk about one of our programs that we're doing within the foundation. It's on oral cancer screening, and it really speaks about the power of coalitions, consortiums. So we have the Oral Cancer Task Force, and it comprises oncologists of national eminence, and we have Tata Memorial Hospital, which is part of this. Then we have Sri Guru Ramdas University at Varanasi, and we have the Homi Baba Cancer Center at Varanasi, and Sri Guru Ramdas at Punjab, Chandigarh. So what has happened is that all these institutes and us, we all came together to understand how is it that we can downstage oral cancer. It's amongst one of the most common NCDs, as you all know. Cancer surveillance, right now what we're focusing on is oral, breast and cervical. Oral cancer was a stated area for us right from 2011 at the foundation. So this was even before CSR actually came into play formally. We formed this body, and I'm so glad to share that today, as a result of this robust research affiliations, we've had more than 44 publications. We've had, in fact, 2 in Nature. We've had 4 patents which have come through for point-of-care devices. We have been able to generate an artificial intelligence algorithm which helps to triage images which are taken at frontline healthcare level. So today what will happen is, if you have an ASHA worker and she has a mobile and she takes the image of a lesion, an oral lesion, it is layered with an AI, and that AI will give you instantly an interpretation, classifying it as whether suspicious or malignant or not malignant. So that is at least a binary classification which is happening. So the power of collaborations is there for everybody to see, and I think I would add to, it's a great segue actually from the previous panel where Mr. Sahu and Mr. Hota, they spoke about icing on the cake or not on the cake, but what I feel is very clearly that CSR has the power, to kind of power innovations. And this is what has happened, at least in our oral cancer screening program. And I'm sure there are so many other success stories out there, but I'm glad that I got the forum to share mine. Thanks.
That's wonderful. And for NCDs, no type of icing is good. So I think we'll take it as that. So we've had a very interesting discussion. We're just drawing it to a close. We've discussed strategies that have worked, models that are showing good results. We've seen why we need to intervene, and innovative models, whether it is BLS training, reaching out into the community, reaching them young, or also advocacy for rare diseases, and how we need to look at innovative use of CSR funds. But as we draw this conversation to a close, I'd like to bring in Dr. Vikas with the discussion on the gorilla in the room, and that really is funding. And as a funder, the person who's signing the check, usually they would like to see quick results. Whereas for NCDs, for rare diseases, like you said, it can be diagnosed up till the age of 7. When we're talking about oral cancer screening, which needs to be done periodically, probably year on year with the same population, especially if they have, tobacco use or alcohol use, etc. How do we sort of marry the two, where there is an expectation of the funder for quicker results, whereas the nature of the beast, as it were, is that it needs a lot more investment, both patient capital and patience?
So thank you, Dr. Karan. For the crowd, I just would like to say that this NCD thing is not just hypertension, diabetes, CVA and all. It has multiple verticals now: tobacco abuse, mental health, even the recent addition of climate change and environmental health. These all comes under our gamut of NCD. So CSR has a broader perspective to invest into this CSR domain. The foremost thing where we need CSR is in process, especially digitization of process. In the first panel, we focused on our CPS services, comprehensive primary healthcare services through health and wellness centers. So we need CSR partners, and as in the first panel again was mentioned, now everyone is talking about primary healthcare. And of course, we need primary healthcare to strengthen, screen, diagnose, treat our NCDs. So the process thing, the digitization, as we know, there are two important windows or two important opportunities where CSR can invest. First is, as our health sub-center, primary health centers and urban primary health centers are converted into health and wellness centers, there is a huge opportunity to augment them through providing point of diagnostic centers, point of diagnostic devices, be it for confirmation fee, for screening or fees, be it for diagnostics. Here again, government have resources, but we have to use our resources very meticulously. There should not be overlapping of it. So optimum utilization of resources also required. Second thing is in direct service provision. The areas which are geographically a little bit challenged or difficult terrain, their CSR can directly involve with government in terms of provision of direct services for screening, be it for, NCDs, both for screening, treatment, or again for palliative. Preconception, counseling, and prenatal diagnosis are very important also again to check NCDs, because in earlier sir mentioned that most of NCDs are traveling from families to traveling, so they have a genetic background. So we have to introduce this pre-genetic and preconceptional counseling thing. We could have a MOU with government in terms of establishing genetic diagnostic centers, which very much required. Under RBSK program, there is a provision of district early intervention centers, which are not very much functional at every district. So here we need CSR to make them functional, have a MOU to establish genetic counseling centers, have a MOU to provide screening of rare diseases also. Then I mentioned about process. So we have these days digitization of family folders or CBAC thing, but how to use that digitized data of family screening for NCDs, here we need CSR support through, and CSR also involve government from the inception of programming. When we are planning to support government initiatives, we should use their data since the inception. And then the resources. Of course, in few setup there is a constraint of resources, be it for health resource, human resource, be it capacity building, drugs, diagnostic, logistics. Here also CSR can be enabler. Coming to Save the Children vision, we are supporting 5 states in terms of establishing comprehensive primary healthcare services through health and wellness centers, where NCD is also a priority. And not to forget about adolescents. India has a data that is mentioning that 80 to 20% of adolescents are indulgent substance abuse or alcohol consumption, and these adolescents, which are like 80 to 20% only, giving a load of 30% of NCDs in adulthood. So we have to plan some strategies to check this substance abuse thing in the adolescent age group, which is giving a load of 30% of NCDs in adulthood. And we have school health and wellness program. CSR can also support this school health and wellness program, where they are supporting 11 themes, and out of 11 themes, 4 themes are directly related to our NCDs, like mental health, substance abuse, use of internet and all. So there also we can plan a strategy along with government. Thank you.
Right. So we've heard for funders in the room the opportunities that exist and the need. You've also heard from Dr. Hiremath why we need to invest further in health and especially in NCDs, rare diseases. You've heard of some models that have worked and why they need to be further expanded. We spoke about the importance of partnerships and collaborations and how they can be force multipliers. And after that wide-ranging discussion, we've only just scratched the surface. But in the interest of time, I'd like to draw this conversation to a close. I'd like to thank all my panelists for their insights and for their suggestions and also for sharing their experiences. It has been a fascinating and a learning experience for me, and thank you once again to the IHW Council for having us all here. Thank you once again. Thank you. Thank you.